This is the show where we try to take some of the densest, most clinical source material out there, the stuff you'd find in textbooks or specialist journals, and really unpack it, transform it into something immediate, actionable, and hopefully truly memorable for you.
And today, we are definitely getting into the weeds on a critical topic. We're looking at Parkinsonism.
Yeah.
Specifically, the absolutely fascinating pharmacology behind the drugs that are used to manage it.
Right. And our sources for this are core textbook excerpts on anti-Parkinsonian drugs. So this gives us a really detailed, very structured, almost like a blueprint of the treatment options.
It does. But, if you read between the lines, it tells this incredible story of pharmaceutical innovation. The mission here is to understand not just the chemical deficit, but the really sophisticated strategies scientists had to invent to overcome the human body's own natural defenses.
Defenses like the blood-brain barrier.
Exactly. We're talking about how to get a vital molecule across the brain's most exclusive security gate. It's a fascinating problem.
So our mission for you, the listener, is kind of twofold. First, to really get a handle on the precise neurochemical imbalance that drives the symptoms of Parkinson's. And second, to dissect the mechanics of the main treatments.
We're going to spend a lot of time on the gold standard drug, levodopa, and then explore its whole supporting cast of other drugs, because none of them really work in isolation.
It's a relentless balancing act, isn't it, where the solution is almost as complicated as the problem itself.
That's a perfect way to put it.
Okay, let's unpack this. I think we have to start right at the beginning. We need to define the clinical reality of what Parkinsonism actually is. So when we say Parkinsonism, we're not just talking about, someone having a tremor. We're defining a very specific kind of extrapyramidal motor disorder. What are those signature features, that core triad of symptoms that really define it clinically?
Okay, so the clinical definition really hangs on three key motor features. The first one is rigidity. That's the stiffness, the resistance you feel if you try to passively move someone's limb. The second is tremor. And it's classically a resting tremor, which is a key distinction. It's a tremor that typically gets better or even disappears when the person deliberately tries to move.
Right, so it's most prominent when they're not doing anything.
Exactly. And the third, and this is perhaps the most defining and frankly the most debilitating, is hypokinesia.
Which means poverty of movement.
Poverty of movement. And that's such an important distinction. It isn't just about moving slowly, which is bradykinesia. Hypokinesia is this profound reduction in movement itself. It's the difficulty in starting a movement and stopping one, and just this general lack of spontaneous action.
You can really see it, can't you? If you watch someone with Parkinson's, that lack of movement it's everywhere.
It is. They might struggle to just turn over in bed, to take these small shuffling steps, and they lose all those little automatic movements that we just take for granted.
Like swinging your arms when you walk.
Exactly like that. We don't think about it, but it's a critical part of our gait. Losing that is a central part of the motor deficit.
And these core symptoms, they don't exist in a vacuum. The source material talks about a lot of secondary manifestations that come along with the disease. What are some of those other telltale signs?
Well, there are several, and they're all related to this loss of subtle automatic muscular control. You see the characteristic posture deficit, that stooped, forward-leaning posture.
Okay.
You also see what's called the mask-like face, or hypomimia. This is where the facial expressions just become flat and diminished. It gives the appearance of emotional detachment, even if the person doesn't feel that way.
That must be so difficult socially.
Terribly. And then quite unpleasantly, there's often coeluria, which is just excessive drooling. And again, it's not because they're producing more saliva. It's a failure of the automatic swallowing reflex.
Wow. And then in the later stages, there are cognitive issues too.
Yes. In the advanced stages, up to a third of patients can go on to develop dementia, which adds a whole other layer of tragedy to the condition.
So this paints a really holistic picture. It's a disease that strips away not just the ability to move with purpose, but also these vital automatic functions and even the ability to display emotion. If we look at the disease trajectory, how does this progress over time?
The progression is tragically relentless. The symptoms just steadily get worse over several years, and it leads to a very severe end stage. The patient becomes rigid, they're unable to move effectively, and critically, they start to struggle with essential functions like breathing and coughing.
And that's where the real danger comes in.
Absolutely. Because of that profound immobility and the difficulty in clearing their lungs, patients sadly succumb mostly to complications, things like chest infections or pulmonary embolisms from being immobile. The loss of coordinated movement eventually just undermines vital bodily functions. Hashtag tag tag 1.2, the pathology of movement control.
So knowing that clinical outcome, we have to ask the question, what is happening in the brain? What's the pathological origin? Where is the switch being flipped?
The origin is very, very specific. The core defect is the selective degeneration of a population of neurons called the nigrostriatal neurons.
Okay, that's a mouthful. Break that down.
So these are the cells that project from a part of the brain called the substantia nigra pars compacta, we'll call it the SNPAC, to another part called the striatum. Think of it like a vital communication line, a superhighway.
Attractive neurons.
Attractive neurons. And their job is to produce one key neurotransmitter, dopamine, or DA.
Right. So we hear so much about dopamine being linked to, pleasure and reward. But what is its function here in the motor system?
That's a great question. In the motor control loop, dopamine is the primary inhibitory system. Its job is to control muscle tone and help coordinate smooth, voluntary movements.
So it's like a dampening system.
It is. Think of motor control as a delicate balance between excitement and inhibition, like driving a car. You need an accelerator and you need a brake.
Okay, I like that analogy. So in this car, what's dopamine? Is it the gas or the brake?
Dopamine is fundamentally the brake. The accelerator, in this context, is the acetylcholine system, the AC system. That's an excitatory neurotransmitter.
So you have this excitatory system, AC, that's always on, always ready to go.
Exactly. And dopamine's job is to modulate it, to apply the brakes, to keep it in check. When you lose those dopamine-producing neurons, you lose the brake.
That's a fantastic way to put it. You've lost the ability to apply inhibition.
And the result of that dopamine deficiency is that the whole system tips into an imbalance. The excitatory A6 system is now dominant, it's running unopposed, and this constant uncontrolled excitation is what causes the motor defects we see. The rigidity, the tremor, the inability to stop or regulate movement effectively.
So the single guiding principle for every single drug we are about to discuss is simply this: restore that balance. Put the brake back in the system.
That is the entire goal of all therapy. Restore the DAC balance, hashtag tag 1.3 historical context, and the discovery of levodopa.
And that understanding, that direct link between the cause and the effect, that's what led to the big breakthrough.
Is everything.
But before that understanding, I imagine treatments were, well, a bit hit or miss. What did they try empirically?
They certainly were. Before the dopamine connection was really established, physicians were using empirical treatments. Most notably, belladonna alkaloids.
Which are anticholinergics. They block the accelerator.
Precisely. So they were trying to restore the balance from the other side. By blocking the excitatory AC system, they could, slightly restore the balance. But the effects were marginal at best.
And then the science finally caught up. When did we move from guessing to actually knowing what was going on?
The major breakthrough really came in the 1950s and 60s. Researchers established that dopamine was present in really high concentrations in the brain. And then came the critical experiments.
What did they do?
Animal experiments show that symptoms that looked a lot like Parkinsonism, for instance, symptoms induced by a drug called reserpine, could be reversed, and reversed rapidly, by giving the animals levodopa, or L-duopia.
And that was the smoking gun.
That was it. It proved that the core problem was a deficiency of dopamine in the central nervous system.
And that led directly to the introduction of L-dopa in 1967 as the first treatment that really addressed the cause itself.
It was a monumental shift in medicine. L-dopa, which is the natural chemical precursor of dopamine, was the perfect candidate. And the reason is, the molecule we really needed, dopamine itself, well, it couldn't get to the brain.
So they had to find a way to sneak the raw materials past security.
Exactly. The goal was to sneak the precursor into the restricted area and let the brain's own machinery do the final assembly.
So L-dopa, the precursor, is introduced, and the results are, they're dramatic. What makes L-dopa the gold standard? What gives it that specific salutary effect that so often exceeds any other drug used alone?
It truly redefined the disease's prognosis overnight. L-dopa has this incredible ability to reverse the hypokinesia and the rigidity that make life so intolerable for these patients. But here's the critical point you have to understand. L-dopa itself is inactive.
It's a prodrug.
It's a prodrug. It has to be absorbed, it has to be transported to those surviving nigrostriatal neurons, and there, an enzyme called dopa decarboxylase, or DDC, converts it into the active neurotransmitter, dopamine.
So it's like a chemical IOU. You give the body L-dopa, and the remaining healthy machinery cashes it in for the real medicine.
That's a great way to think about it. It's a highly targeted replacement therapy that actually leverages the remaining healthy parts of the system.
And once that payload of dopamine is delivered inside the central nervous system, what happens?
The results are just remarkable symptomatic improvements. The source material notes that rigidity and hypokinesia resolve first. Mobility returns, which is absolutely life-changing for someone who was frozen. Tremor often improves a bit later.
But beyond just the physical movement, you mentioned that L-DOPA has this profound psychological effect, a general alerting response. What does that actually mean for the patient?
Well, it can be a really powerful boost in energy and alertness, which can be great, but it can also be very destabilizing. This response can manifest as excitement, agitation, insomnia, and worryingly, in some cases, frank psychosis.
So we're talking hallucinations, delusions.
Yes, exactly. And this activation is a direct consequence of overstimulating dopamine pathways, not just the motor ones, but also the limbic pathways that are involved in mood, reward, and thought. Hashtag 2.2, the challenge of pharmacokinetics, why LDOPA needs help.
Okay, so the efficacy is undeniable, but this brings us to the core problem, the real dilemma, and the reason L-DOPA has to be managed so carefully. It's pharmacokinetics. Getting this powerful drug where it needs to go is incredibly difficult because the body is actively trying to prevent it. Let's start with the fundamental barrier problem.
This is the brain's ultimate security system. The blood-brain barrier, the BBB. It's designed to keep out large molecules, polar molecules, potentially harmful things that are circulating in our bloodstream. And dopamine itself, the molecule we desperately need in the brain, is large and polar. It simply cannot cross this barrier. It is locked out.
So we have to find a molecule that can trick the security system, and that molecule is L-DOPA.
Yes, L-DOPA is structurally different enough that it can sneak past. It uses an active transport mechanism, basically specific protein channels on the brain capillaries, to get ferried across the BBB. But this journey is incredibly perilous. L-DOPA is under constant attack from the moment it's ingested.
And that attack is the decarboxylation problem. Can you just explain the sheer inefficiency of L-DOPA when it's given alone?
This is truly astonishing. When a patient takes an oral dose of L-DOPA, more than 95% of that dose is converted into active dopamine in the peripheral tissues, so in the gut and the liver, before it has any chance to reach the brain.
95%.
More than 95%. We are talking about maybe 1 to 2% of the dose actually making it across the BBB to do its job. The body essentially sabotages the vast majority of the drug before it gets to the target.
That's a 95% failure rate, which means 95% of the dose is now circulating as active peripheral dopamine, which is exactly where we do not want it. What kind of havoc does this peripheral dopamine wreak?
It causes critical dose-limiting side effects, and it primarily hits two places, the cardiovascular system, or CVS, and a place called the chemoreceptor trigger zone, or CTZ.
Okay, let's start with the heart and the CVS issues. What happens there?
This peripheral dopamine acts on beta-adrenergic receptors. This typically causes tachycardia, so an elevated heart rate. But more concerning for patient safety, LDOPA very frequently leads to postural hypotension.
Okay, so postural hypotension means your blood pressure plummets when you stand up. What does that actually feel like for the patient?
It causes acute dizziness, lightheadedness, and a very high risk of fainting, especially when they're going from sitting or lying down to standing. If a patient is already elderly or has underlying heart issues, this peripheral DA action complicates their entire medical profile.
Yeah.
It makes them a huge fall risk and puts a significant strain on their cardiac function.
Right. And the other system affected is the CTZ. This relates directly to the patient's immediate comfort level, doesn't it?
It does. The chemoreceptor trigger zone is a specialized area of the brain that detects toxins in the blood and triggers vomiting. Critically, the CTZ sits outside the protection of the BBB.
Ah, so it's a weak point in the armor.
It's a deliberate weak point, so the brain can detect poisons. And peripheral dopamine gains easy access here. It acts as a powerful excitatory transmitter and strongly elicits intense nausea and vomiting. For a patient, this can be absolutely miserable, and it often forces them to abandon the therapy altogether in the early days.
So just to sum up, L-DOPA alone is a mess. The body converts 95% of it into a chemical that causes nausea, vomiting, and cardiovascular stress, all while only 1 or 2% actually makes it to the target. Hashtag 2.3 endocrine and metabolite effects.
And if that wasn't enough of a challenge, we also have to contend with its incredibly rapid degradation. LDOA is absorbed quickly, but it's also metabolized and eliminated very, very quickly.
So beyond that DDC enzyme we just discussed, what are the other major metabolic routes that chew it up?
There are two other main pathways. The first is O-methylation by an enzyme called KOMT, that's catechol-methyltransferase, and the second is oxidative deamination by MAO monoamine oxidase.
We'll be coming back to both of those later.
We will. But both of these pathways contribute to L-dopa having an extremely short biological half-life, or T1 half, of only 1 to 2 hours. This very short duration of action is a huge problem for trying to maintain stable symptom relief throughout the day.
And what about the endocrine action? The source mentions prolactin.
Right. So dopamine has a natural function in the pituitary gland, where it strongly inhibits the release of a hormone called prolactin. This is actually a neat biological detail. If a drug is successfully getting into the systemic circulation and being converted to dopamine, you can often see a measurable decrease in prolactin levels. It can serve as a valuable biological marker that the drug is having an effect.
This sounds like an absolutely impossible chemical engineering problem. The body is too fast, it's too efficient at destroying the drug in the wrong place, and the drug we need can't get across the border on its own. We need a targeted intervention. This brings us to the truly brilliant solution: the combination strategy using peripheral decarboxylase inhibitors.
This is where the pharmaceutical design really shines. These inhibitors, primarily two drugs called carbidopa and benserazide, are essentially peripheral shields. They work by inhibiting that dopa decarboxylase enzyme, the DDC, the very enzyme that causes that 95% peripheral destruction we talked about.
But the truly ingenious part is their structure. They are designed to only act on the periphery, right? They can't get into the brain themselves.
That is the absolute essential trick. These PDIs are specifically engineered to be water-soluble and polar, which means they do not penetrate the blood-brain barrier. So they patrol the peripheral circulation, acting like security guards that prevent DDC from converting L-dopa into dopamine in the gut and the liver.
So carbidopa and benserazide prevent the sabotage outside the brain, leaving L-dopa free to continue its journey unharmed. What are the measurable clinical benefits of this combination, which is known as co-carbidopa?
The benefits are transformative, which is why this combination is now the definitive standard of care. It has completely replaced L-dopa alone. There are really 4 major wins.
Okay, what's the first?
First, we drastically increase the amount of L-dopa that's available to cross the BBB. This means you get a much higher, much more effective concentration of dopamine in the CNS. Second, and just as important, we dramatically reduce that peripheral dopamine formation. Which virtually eliminates the severe nausea, the vomiting, and most of the cardiac complications. The side effects that used to limit the dosage are basically gone.
So the side effects are gone, and the central effect is enhanced. What's the third benefit?
We see a crucial prolongation of L-dopa's half-life. By blocking that main DDC degradation pathway, the elimination rate is significantly reduced, often to about 1/4 of the previous very rapid rate. This smoothing effect makes dosing much more manageable for the patient.
And there's a fourth benefit, a neat chemical interaction you mentioned before, the issue with vitamin B6.
Yes, pyridoxine, or vitamin B6, acts as a cofactor that actively enhances peripheral decarboxylation. When L-dopa was given alone, a patient taking a simple vitamin supplement with B6 could essentially render their Parkinson's treatment useless.
It would just chew up the L-dopa even faster.
Exactly. But with carbidopa present as that PDI shield, this interaction is completely neutralized, meaning patients can now take their essential vitamins without any fear of treatment failure. Hashtag 3.2, advanced complications of chronic levodopa therapy.
Okay, so the combination therapy solved the immediate problems of peripheral side effects and poor absorption. But decades of use have now shown us that L-dopa creates a new, entirely different set of challenges over the long term. What is the most common motor complication we see after chronic use?
After a few months to a few years, typically the window is about 4 to 8 years, about half of all patients develop these severe motor abnormalities called dyskinesias.
These are involuntary chorioauthotoid movements.
Right. That's a complex term. But what it looks like is, well, it's uncontrolled, writhing, swinging of the limbs, facial grimacing, twisting movements of the trunk. It can be highly disabling. And often to a casual observer, it looks worse than the initial Parkinsonian symptoms themselves.
That is the cruelest irony, isn't it? The drug that solved the poverty of movement is now causing an excess of unwanted movement.
It is, and the intensity of these dyskinesias correlates directly with the L-dopa levels in the blood. They tend to peak when the L-dopa concentration is at its highest.
Which means to control the dyskinesia, Doctors often have to reduce the dose, which then risks a return of the original rigidity and slowness.
It's a constant, vicious tightrope walk.
And the other major complication that really dictates advanced therapy is the severe fluctuation in motor performance. That initial, steady, predictable response starts to break down.
This is perhaps the greatest challenge in advanced Parkinson's disease. The first type of fluctuation is what's called the wearing off effect. This one is at least predictable. The therapeutic response shortens, and patients can literally feel the return of their symptoms, the rigidity, the slowness at the end of their dose interval. They know when their next pill is due because they start to crash.
But the on-off phenomenon is far more challenging, isn't it? Because it's so unpredictable.
Exactly. The on-off effect involves these rapid, unpredictable swings between periods of good mobility, what's called on time, and periods of profound, sudden immobility, the off time.
So they can go from walking normally to being completely frozen in a matter of minutes.
Yes, and it's completely unrelated to their dosing schedule. This renders the patient highly disabled because they just can't rely on their body's function from 1 hour to the next.
Why does this happen? Is the drug suddenly failing, or is the disease just getting worse?
It's a combination of both. As the disease progresses, the remaining dopamine-producing neurons lose their ability to store and buffer the dopamine that's synthesized from L-DOPA.
So in the early stages, those neurons act like a reservoir.
Yes, they act like a reservoir, smoothing out the peaks and troughs of the orally administered drug. But in the advanced stages, that buffering capacity is lost. So the LDBA gets converted into dopamine in this rapid, impulsive burst, which leads to peak-related side effects like the dyskinesias, followed by a sharp drop-off into the off state.
That contextualizes the problem perfectly. The drug needs the surviving neurons to function as a stabilizer, and when those stabilizers die off, the ride becomes violently bumpy.
That's a perfect way to describe it. And we can't ignore the behavioral effects that complicate all this even further. As we mentioned, L-DOPA is a very powerful psychoactive drug.
So what are the common psychological side effects that we see chronically?
Well, they can range from severe emotional responses, things like depression, mania, generalized anxiety, to more acute neurological disturbances like mental confusion, vivid nightmares, hallucinations, and, as we said, frank psychosis.
And the source material highlights that this psychosis is often made worse by drug interactions.
Yes, particularly if the patient is put on a typical antidopaminergic medication to try and control the psychosis. That could be a disaster. Hashtag tag 3.3, key drug interactions to avoid. Here's where it gets really interesting.
This brings us to a really crucial segment for any clinician or, frankly, anyone caring for a patient on L-DOPA. There are some critical drug interactions that can either render the therapy useless or create a genuine medical emergency. What are the key medication classes that absolutely must be avoided or managed with extreme caution?
The first, and maybe the most counterintuitive, are the antipsychotics. Drugs that are commonly used to treat severe psychological symptoms. Things like phenothiazines, butyrophenones, and even the anti-nausea drug metoclopramide work by blocking dopamine receptors.
So if L-DOPA is desperately trying to fill those receptors with dopamine and you introduce a drug that blocks them, you completely reverse the therapeutic effect.
Precisely. You are fighting yourself chemically. If a patient develops L-DOPA-induced psychosis, treating them with a typical antipsychotic can immediately and severely worsen their Parkinsonian motor symptoms. It's a huge clinical pitfall.
So what's the second major interaction that presents a really catastrophic risk?
That would be the non-selective MAO inhibitors. We talked about MAO, monoamine oxidase, being an enzyme that degrades dopamine and noradrenaline. If you combine L-DOPA with a non-selective MAO inhibitor, one that blocks the degradation of both of those substances, you get this dangerous buildup of both DA and noradrenaline in the periphery.
And that can trigger what?
A severe, life-threatening hypertensive crisis. It's a critical contraindication. A massive spike in blood pressure.
That sounds like a stroke waiting to happen. Finally, what about medications for blood pressure itself? Antihypertensives.
They have to be used with extreme caution. Since L-DOPA already causes postural hypotension as a common side effect, combining it with other drugs that are designed to lower blood pressure can dangerously exacerbate that hypotension. It dramatically increases the risk of falls and syncope, or fainting.
So if L-DOPA is the best, most powerful drug we have, the supporting cast is what allows us to manage its flaws, stabilize its effect, and, importantly, delay its use. Let's start with the dopaminergic agonists. How do they fundamentally differ from L-DOPA's mechanism? Hashtag 4.1 dopaminergic agonists, DA agonists.
Right, so L-DOPA requires the patient's surviving neurons to convert it and then release it. The DA agonists skip that entire step. They are molecules that are designed to look enough like dopamine that they can directly stimulate the dopamine receptors themselves, day 1 through D5.
So they bypass the need for any of that remaining synthetic or storage capacity in the dying neurons.
Exactly. They don't need the factory to be working. This makes them ideal for advanced patients who have lost most of their dopamine neurons and can no longer effectively convert LD by A.
Which ones are used most frequently as a first-line therapy today?
The current leaders in this class are ropinirole and pramipexole. They are non-ergoline drugs, and they're selective DTD3 agonists. We're seeing these used more and more as a first-line monotherapy, especially in younger patients.
And the strategy there is what?
The major strategic advantage is that starting a patient on an agonist can delay the introduction of LD-DOPA, and therefore it delays the onset of those severe LD-bike-induced motor complications like dyskinesias. Some studies even hint that they might retard disease progression, though that's still an active area of research.
But the agonists, they bring their own notorious side effect profile, don't they? Specifically the ones that affect personality and behavior.
They absolutely do. The common physical side effects are what you'd expect from increasing central dopamine activity, nausea, dizziness, hallucinations. But the most profound and concerning side effect is their link to impulse control disorders.
What does that mean exactly?
These can manifest as hypersexuality, pathological shopping, and compulsive behaviors like severe life-ruining gambling.
That is just a staggering implication, that a drug you take to help you walk can fundamentally change your personality and destroy your life financially.
It requires extreme vigilance from both the clinician and the family. It's a direct result of overstimulating the brain's reward pathways, and it really demonstrates the profound link between dopamine and impulse control.
What about the older agonists, like bromocriptine? Are they still used?
Bromocriptine is an older option. It's an ergot derivative, and it acts as a partial D2 agonist. While it's still effective, it has a more troublesome side effect profile. It's notably associated with a marked fall in blood pressure, a first dose effect, which means you have to titrate the dose up very, very slowly and carefully. The newer non-ergoline drugs are generally favored now because of their improved tolerance. #4.2 MAOB inhibitors focus on preserving existing DA.
Okay, moving to the second category of supportive drugs, the MAOB inhibitors. If L-DOPA adds dopamine and agonists imitate dopamine, these drugs are all about preservation.
That is the perfect distinction. These drugs selectively inhibit an enzyme called monoamine oxidase B, or MAOB, at low doses. And MAOB is the central enzyme that's responsible for degrading dopamine and noradrenaline inside the brain.
So by blocking it.
By blocking it, you ensure that the dopamine that's already been synthesized by the surviving neurons or delivered via LDOP just stays around longer and works harder. You're preserving what you've got.
The primary drug here for a long time has been Selegiline. What does it achieve when you add it to L-DOPA therapy?
Selegiline, or deprenyl, is used as an adjunct to L-DOPA. Clinically, it's very valuable because it can often reduce the necessary L-DOPA dose by 10 to 30%. And it significantly helps to smooth out those debilitating motor fluctuations, especially the wearing off effect. If you preserve the available dopamine, the effect of each dose just lasts longer.
But Selegiline has a structural problem built right into its metabolism, doesn't it?
It does, and it's a significant one. Selegiline is metabolized in part to active amphetamine and methamphetamine.
Wow.
Yes. And this can lead to some unwanted central side effects like insomnia, agitation, and a general feeling of excitability. Furthermore, it has a dangerous and potentially fatal interaction with the opioid pain medication pethidine, which can cause severe reactions. You have to avoid that combination entirely.
So given that metabolite issue, the development of risagiline must have been a really welcome advancement.
Immensely welcome. Risagiline is a newer inhibitor. It's about 5 times more potent than Selegiline, and critically, it is not metabolized to amphetamine or methamphetamine. This gives it a significantly cleaner side effect profile. You get the excellent dopamine preservation without the amphetamine-related agitation and insomnia. #4.3 COMT inhibitors blocking the alternate degradation pathway.
Okay, we mentioned COMT briefly earlier in the context of L-DOPA's rapid metabolism. Now we're introducing the COMT inhibitors as a specific drug class to optimize L-DOPA even further. Why is blocking this enzyme necessary when we already have the PDI shield from carbidopa?
This brings us back to the 2 main ways that L-DOPA is destroyed in the periphery. Carbidopa blocks dopa decarboxylase, or DDC, But L-DOPA is also broken down by that other enzyme, COMT catechol-amethyltransferase.
Okay.
When creatine P acts on L-DOPA, it creates a metabolite called 3-O-methyl-DOPA, or 3-OMD.
And 3-OMD is the silent competitor.
Exactly. 3-OMD is a problem because it's structurally very similar to L-DOPA. This means it competes directly with L-DOPA for that crucial active transport mechanism to cross the blood-brain barrier. So if 3-OMD is hogging all the transport channels, less L-DOPA gets in.
So by blocking COMT, we reduce the amount of this competitor, 3-OMD, and we free up the transport channels for L-DOPA to use. Which are the drugs here?
We have two main ones, tolcapone and entacapone. They are used exclusively as adjuvants to the L-DOPA-carbidopa combination, and their goal is to increase the total duration of on time and effectively smooth out that wearing off effect.
Are they interchangeable? I think you mentioned a pretty significant safety profile difference between them.
They are critically different, and this is a classic example of balancing efficacy and toxicity.
Yeah.
Tolcapone acts both centrally and peripherally. So it blocks COMT in the circulation and also inside the brain, which might offer a slightly stronger effect. But tolcapone carries a significant and potentially fatal risk of hepatic toxicity. Liver failure. This means its use is severely restricted, it requires intense monitoring, and so it's very rarely used today.
A major liability. What about entacapone?
Entacapone is the preferred drug because it's much safer. It acts only peripherally. It blocks COMT in the gut and the liver, but it does not cross the BBB. This makes it much safer in terms of liver toxicity. It's generally well tolerated, although a common dose-limiting side effect, which affects 10 to 18% of patients, is diarrhea. Hashtag tag 4.4. Other symptomatic treatments.
Okay, before we pull this all together into a final treatment strategy, let's briefly touch on two other classes that act on entirely different pathways. First up, amantadine.
Amantadine is a real outlier. It was initially developed and approved as an antiviral drug for influenza A. But serendipitously, it was found to provide some mild benefit in Parkinson's disease.
Its mechanism is still a bit fuzzy, right?
It is. The current theories suggest it may enhance the synthesis or the release of dopamine from nerve endings, but it also acts as an NMDA receptor antagonist.
An NMDA receptor antagonist. So that means it blocks the effect of glutamate, which is another powerful excitatory neurotransmitter. So it's another way of reducing the excitatory side of that DA balance.
Correct. Its main value today is actually in treating the LDIA-induced dyskinesias. It can often help reduce those awful involuntary movements. Its own side effects include things like insomnia, restlessness, and hallucinations. But the highly unique side effect is something called livedo reticularis.
What on earth is that?
It's a benign but very distinctive bluish, mottled, almost net-like discoloration of the skin, usually on the legs.
That is certainly a memorable side effect. Okay, finally, let's go all the way back to the beginning, to that original DAA balance with the central anticholinergics.
These are drugs like trihexyphenidyl. They were the earliest effective treatments before we knew about dopamine. They ignore the dopamine deficit entirely and just focus on blocking the overactive acetylcholine system.
So they're the chemical equivalent of loosening the accelerator rather than fixing the brake.
That's a great analogy.
If they address the underlying imbalance, why are they considered sort of a last resort now?
Well, for one, they're much less effective than L-DOPA. They offer maybe 10 to 25% improvement in symptoms, at best. Their main use now is in very mild cases, particularly when tremor is the dominant symptom, or to treat drug-induced Parkinsonism, like the kind caused by antipsychotics.
But the real limiting factor is the side effect profile, especially in older patients.
Absolutely. This is the real problem. Anticholinergics inhibit systems throughout the body. Centrally, in the brain, they cause impaired memory, confusion, and can even precipitate acute psychosis. Peripherally, they cause dry mouth, blurred vision, constipation, and most concerningly, urinary retention. For an older patient population, these side effects can be acutely debilitating and dangerous.
Okay, so we've covered 5 distinct classes of drugs, all aiming for the same goal: dopamine replacement or conservation. If we synthesize all of this, what is the modern strategic goal of managing Parkinson's disease? Hashtag TAC 5.1 goals and early therapy.
The overarching goal, according to all the sources, is strictly symptom relief and maximizing the patient's quality of life. And we have to be very clear about this. Currently, no drugs are definitively proven to alter the progressive course of the disease. We are managing symptoms, not providing a cure.
That's a sobering but important point.
It is. That said, research is always ongoing, and some drugs, particularly those MAOB inhibitors, show some hints of potential neuroprotective effects that could theoretically slow the progression. But that's not proven yet.
So, given the incredible power of L-Dopa, but its inevitable, nasty, long-term side effects, the dyskinesias and the fluctuations, what's the current thinking about when to introduce the gold standard?
The strategy is simple. Delay L-Dopa for as long as you possibly can. The severity of the long-term motor complications appears to be linked directly to the duration of L-Dopa exposure, not necessarily the dose.
So, in younger patients or those with milder disease, what is the first line of defense?
Initial monotherapy generally begins with one of the newer DA agonists, like ropinirole or pramipexole, or the cleaner MAOB inhibitor, resegeline. These drugs can offer sufficient symptomatic relief in the early stages while keeping L-Dopa on the bench. The goal is to start L-Dopa only when the disease severity demands the superior efficacy that it provides. ### 5.2, the standard in advanced therapy. Once L-Dopa is finally introduced, usually as the L-Dopa-carbidopa combination, it provides its best, most stable benefit for about 2 to 3 years. But as the disease progresses and those motor fluctuations start to dominate the picture, the on-off periods, the strategy has to become increasingly complex.
So, how does the strategy change when the patient starts experiencing those debilitating rapid swings between mobility and immobility?
The management becomes a constant, precise titration. We start using the supporting cast to stabilize the L-Dopa base. The first adjuvant we might look to is often a KOMT inhibitor, typically entacapone, to prolong the biological half-life of L-Dopa and increase the patient's total on time.
And if that's not enough?
Alternatively, or sometimes additionally, we add a DA agonist to the mix. The goal there is to provide a continuous, direct stimulation of the dopamine receptors, which helps to smooth out the sudden drops in LDTA effect.
It really sounds like a chemical ecosystem designed around one central, highly effective but highly unstable drug.
That is exactly the reality of it. We are attempting to impose pharmacological stability on a biological system that is dying and becoming inherently unstable. Everything we do is about trying to smooth that pharmacokinetic curve to deliver a more continuous, non-pulsatile stimulation to the dopamine receptors. #tag 5.3 outdated practice.
Finally, you mentioned one historical practice that sounds incredibly harsh, but it was once used to try and reset the system. What was the drug holiday, and why is it no longer done?
Right. The practice of a drug holiday involved withdrawing L-Dopa completely for a period ranging from 4 to 21 days. This was usually carried out in a monitored hospital setting. The hope was that this withdrawal would allow the striatal dopamine receptors, which may have become desensitized over time, to reset and restore their responsiveness.
And did it work?
Occasionally, patients would see a modest temporary benefit, but the risks were just astronomical. Withdrawing the primary source of dopamine replacement could lead to marked profound rigidity, acute inability to move, and even respiratory failure. It sometimes mimicked a condition called neuroleptic malignant syndrome. The risks just far outweighed any potential clinical benefits, and this practice has now been definitively abandoned. #OTRO.
This has been a really fascinating journey into the dopamine dilemma. It's so clear that Parkinson's management is not a single treatment path, but a constant, dynamic titration against a progressive loss of neural function.
Absolutely. The core lesson here is that PD management hinges on this delicate balance. You're balancing the profound, immediate, life-changing effectiveness of L-Dopa against the inevitable, often severe long-term motor complications like dyskinesia and the on-off fluctuation.
And the entire supporting cast.
The entire supporting cast of drugs, the agonists, the MAOB inhibitors, the COMT inhibitors, it all exists primarily to conserve the efficacy of L-Dopa and to smooth out its unstable delivery.
It's a strategy designed to buy time and maintain quality of life against a ticking clock.
And that leads us to our final provocative thought for you to chew on. The fact that the most debilitating long-term side effects of treatment, specifically the dyskinesias and the fluctuations, appear to be tied directly to the duration of exposure to L-Dopa, often appearing 4 to 8 years after the drug is started. This forces clinicians into an incredibly difficult trade-off.
Which is what?
Should a doctor delay the introduction of the best possible symptomatic relief now, thereby forcing the patient to live with greater disability today, simply to reduce the risk of drug-induced movement disorders 4, 5, 8 years down the line? It is a constant, agonizing clinical challenge that really defines the modern management of Parkinson's disease.
A tough, ethical, and clinical knot to untangle. Thank you for joining us for this deep dive into the pharmacology of Parkinsonism. We'll see you next time.